Good afternoon, everyone. My name is Cindy James. I am a genetic counselor and geneticist at Johns Hopkins, and really excited to have this opportunity to share with you today a little bit of the clinical research we're doing in the ARVC program. So in the next 10 minutes or so, I will describe our approach to research, share some of the recent successful research initiatives we've been doing, and then thank you for your participation in research and introduce you to a few studies enrolling now. In clinical research, particularly clinical research for a relatively rare condition, participation of patients and families is key. We wouldn't make progress without you. All right, so at Johns Hopkins, our approach to unlocking the mysteries of ARVC is multidisciplinary research. You'll hear a little bit from my colleague, Dr. Stephen Chelko, next, and you'll see that we do research that ranges all the way from DNA and molecular analysis, all the way to studies looking at how ARVC impacts families. We also prioritize collegial and collaborative research. This is a picture from the 20th anniversary of the Johns Hopkins ARVC program at a conference we had in Baltimore before COVID, about 18 months ago. And these are ARVC experts literally from around the world, but they're also our colleagues in rare disease. It's not possible to make progress without collaboration. And finally, our approach highlights you. We aim to deliver news you can use to make good decisions about your medical care, and we really aim to provide the information you need to personalize your care. And the heart of our approach to this work is our ARVC registry. This is an observational longitudinal study that now includes nearly 2,000 patients with or affected in their family by ARVC. It includes nearly 1,000 DNA samples we've collected and stored, a bunch of exercise interviews, literally thousands of completed questionnaires. If you're interested in joining our registry and are part of a family affected by ARVC or another arrhythmogenic cardiomyopathy, please call Crystal or email Crystal. We'd love to have you. All right, so I'm going to move next to share a little bit of, about a few of our recent research successes. A couple of years ago, we came together as a group of ARVC experts from 6 centers, literally around the world, to try to address the question of, if you're diagnosed with ARVC but have not yet had a first sustained ventricular arrhythmia, what's your chance of developing one in the next couple of years? And what that risk is obviously has major implications for your decision of whether or not to get an ICD, of what medication to take, and so on. So this study was led by Julia Cadrin-Tourigny, who is a electrophysiologist now up in Montreal. At the time she was a postdoc with us. And then co-led by myself and Annelien Terreel, who is a cardiologist in training in the Netherlands. And so we took data from nearly 600 ARVC patients who were diagnosed according to task force criteria, but hadn't yet had a sustained VT when they were diagnosed, and developed a model for individualized risk prediction. And so in that model, you actually can follow the link and go there. You plug in your sex, your age at diagnosis, whether or not you'd passed out recently, if you had evidence of non-sustained VT on Holter, what your PVC count looked like on your Holter monitor, what your ECG looked like, how many T-wave inversions you had, and then how well the right side of your heart was squeezing, what your right ventricular ejection fraction was. You plug it all in and it spits out a 5-year risk, which we think is pretty useful. Obviously, we weren't done with just that model. And so we're now working on studies that ask, well, how about in people that are high-level athletes? Does the calculator work? Initial analysis done by our current ARVC fellow, Alessio Gasparetti, who looked at the function of the risk calculator in a small group of Italian patients, suggests that it does. We have preliminary data from our cohort suggesting it does it as well. We're also working to see, can we predict very rapid ventricular tachycardia, or VF? That's the really fast ventricular arrhythmias that are particularly life-threatening. We have a paper that should be accepted any day now with a modification to the risk calculator suggesting we can. There's other questions as well. How can we make the model better? Can an electrophysiology study help refine risk? Can we make the calculator update in real time? And for that, stay tuned. We continue to work with our colleagues around the world on those questions. As I imagine you've heard from Dr. Calkins already today, we know that exercise in someone already diagnosed with ARVC, particularly high intensity or vigorous exercise, is associated with worse outcomes. More ventricular arrhythmias, worse ventricular structure and function. But there's less data in at-risk relatives. So if you are a member of a family with ARVC and have an ARVC-associated mutation, what is the right amount of exercise for you? That's a harder question. We think there's a dose-dependent increase in the amount of vigorous exercise someone does and the likelihood of developing ARVC. There's some evidence for association of exercise with worse right and left ventricular function, but frankly, there's less data than for affected individuals. So for people who already meet task force criteria, and most of that data is from PKP2 carriers. So over the last couple of years, we have been working on that question. This is a study led by Weijia Wang, who is an ARVC fellow, and he'll be coming back to us at Johns Hopkins as an electrophysiology fellow soon. He looked at data from 101 relatives with mutations, again, most of them PKP2, and he found that among the 44 who had ARVC, who met task force criteria, those who did relatively little exercise, but exercise up to the amount recommended by the AHA for healthy adults, were far less likely to develop disease and far less likely to be among the group who developed VT. This section over here with the dots shows that even though sometimes we think, at least from an arrhythmia perspective, males have worse outcomes than females, here you can see that the difference in outcomes between athletes and non-athletes was particularly large in female family members. So we think sort of girls and women who are high-level athletes who have desmosomal mutations may be at particularly high risk of going on to develop ARVC. I told you most of the data is from family members with PKP2 variants. Here's a study we recently completed in collaboration with our colleagues in the Netherlands of the outcomes of carriers of a phospholamban founder variant. That founder variant comes from the Netherlands, but for families with PLN variants in the US, most of them have the same founder variant. And here you can see different from the outcomes of the PKP2 carriers. There is no difference in outcomes of family members who were athletic and non-athletic who have this PLN founder variant. You can see the red and blue lines sit on top of each other. So it's a very different story than what we're seeing for PKP2. The third line of research I want to share with you today is a little bit of our work on genetics and inheritance. When you talk to your genetic counselor, and certainly I imagine as you heard from Brittany earlier today, we think of ARVC classically as an autosomal dominant disease with reduced age-related penetrance and variable expressivity. And this is just a pedigree of a family showing that pattern pretty nicely. But we know in real life, in clinic, and maybe even in your families, we see many isolated cases. So here's a family with just this 22-year-old man in blue who's affected with ARVC, even though his dad and brother have the same mutation. And here's a bigger family with only one affected individual. We have spent quite a bit of time in the last couple of years trying to dig into the genetic architecture of ARVC. And we have found in collaboration this study with, again, the Dutch as well as a German group, that these desmosomal variants, so PKP2, DSP, and others, are inherited, which means that almost always, if you have been found to have a desmosomal genetic mutation, a desmosomal variant, you inherited it from your mom or dad. We all know mutations have to start somewhere, but new mutations in desmosomal genes in ARVC are really rare. Furthermore, we found that these mutations have been hanging around in the human population for probably hundreds, if not thousands of years. And we found that out by looking at the DNA around the ARVC mutation and comparing what that DNA looked like in the US, in the Netherlands, and in Germany. And what we found is that most people, even though we didn't know they were related, they didn't even know they were related, that share the same genetic mutation, have evidence that they're inherited, that they're related generations back to other people who have that same mutation. So we say these arise from ancient founders. These mutations have been there a long time. And that's important because it means that, well, practically, that informs your strategy for genetic testing in your family, but also points to the likelihood that there are some important genetic modifiers related to if you're born with a mutation, how severely will you get ARVD? Will you get ARVD at all? And we are working with colleagues around the world on a multi-center study to try to find those genetic modifiers. And so that's a GWAS study. We know that endurance exercise, high-level vigorous exercise, is also an important modifier. And then finally, at Johns Hopkins, we are working with a group of select families to try to identify those genetic modifiers here. All right, so finally, I'll end by again thanking you for your participation in research. I think it's pretty clear from some of the research initiatives I showed with you, we wouldn't be making any progress without you sharing your medical records, your DNA, your exercise history with us. If you want to help, again, please call or email Crystal if you're interested in joining our registry. You don't have to come to Baltimore. This is really working with us to submit medical records, participate in questionnaires and interviews, and possibly submit a DNA sample. And finally, I'll just close with my sincere thanks to you and your families. All of you helped establish our program, have helped support applications for funding, have shared your data. We want to continue to work with you. Please ask questions and send your ideas for research. Thank you very much.
Well, I'd like to introduce myself. My name is Stephen Shelka. I'm an assistant professor of biomedical sciences at Florida State University College of Medicine. And I also hold an adjunct assistant professor position at Johns Hopkins, where I've been for the past 8 years until recently. And I've been working closely with the ARVC program for those past 8 years. I'm going to be talking about myocardial inflammation, a pathologically prevalent phenotype in arrhythmogenic cardiomyopathy. I've heard previously about the functional characteristics such as the ventricular arrhythmias and dysfunction. I'm going to talk about one pathological characteristic in particular, inflammation. So the reason this is important is because this is highly prevalent in ARVD, or arrhythmogenic cardiomyopathy. As you can appreciate here on the left side of the screen, in an ACM patient, this is indicative of a lot of inflammatory infiltrates. So professional immune cells such as monocytes, macrophages, T cells. They can cause local inflammation as well as contribute to cell death. Of course, when you have cell death, if the clearing, such as the autophagic clearing, is not properly handled, it can lead to epicardial and endocardial fibrosis. As you can see here from a patient that this is an explanted heart, you can see their ICD lead, but you can really appreciate the biventricular fibrosis. There's a little bit of red meat right here, as they say, dead meat don't beat. However, in the right ventricle, this is practically just fat. Every time I look at this, I always think it's a big booger. Sadly, when you have a lot of fibrosis, you get one of the most common features, which is called ventricular or reventricular tachycardia. So, as you've heard, you can have ARVD due to meeting task force criteria for ARVD, as well as having a mutation in one of the 5 desmosomal genes. Disruption of the desmosome leads to myocyte uncoupling, which leads to mechanical and electrical uncoupling, which contributes to the arrhythmias and the ventricular dysfunction, as I previously stated. However, I'm particularly interested in inflammation, which leads to cell death and fibrosis, which contributes to the pathological remodeling. And I do this utilizing a desmosomal ACM mouse model, which I've termed the desmoglein 2 mutant mouse. So desmoglein-2 mutant mice recapitulate ARVD via loss of function. Thus, they don't produce any DSG2 protein, so which can be visualized here by a Western immunoblot, as well as not only is the protein not made, but it's not shuttled to the intercalated disc. You can appreciate here is an intercalated disc. Here's an intercalated disc. It should be showing up right around here, but you can see in wild type clearly the DSG2 protein is made as well as it's shuttled to the intercalated disc, maintaining that myocyte-myocyte connection. My mice, the desmoglein-2 mutant mice develop disease very, very quickly. Early adolescence, by 8 weeks of age, they have left ventricular dysfunction, as can be assessed here via echo, with reduced percent ejection fraction and fractional shortening, as well as biventricular fibrosis. Via gross pathology, you can see on the right ventricular wall and near the left ventricular free wall near the apex. You can see here, there's clearly lots and lots of fibrotic remodeling as stained in blue. So previously, I showed that disruption of the desmosome activates GSK3 beta, which stands for glycogen synthase kinase 3 beta. This kinase, its sole responsibility is to phosphorylate serine and threonine sites or amino acid residues. One of those is on beta-catenin, which is structurally and functionally similar to gamma-catenin, aka glycoglobin. So when GSK3 beta phosphorylates beta-catenin, it leads to beta-catenin degradation and a plethora of ACM phenotypes. So we used this small molecule compound called SP216763, which targets at GSK3 beta, sequesters it, and leads to segregation. And it really, really improved a lot of the functional and pathological phenotypes when we tested this in mice. However, we took that drug to GlaxoSmithKline to do testing in larger animals. And they came back and said to these mice, or these rabbits, sorry, that we were testing the safety of it, that they came back with lots and lots of intestinal tumors. So of course, we don't want to give a drug like this to a patient. They come back to Hugh Hopkins a year later and say, oh God, my heart is great, it's fantastic, but I have intestinal cancer. Probably not the best way to treat a patient. So of course, as a basic researcher, I'm very interested in cell signaling cascades, so from upstream to downstream signaling. So we looked at something further down from GSK3 beta. Specifically, GSK3 beta, like I said before, it phosphorylates target proteins to either activate or degrade them. In this case, when it phosphorylates the P65 unit of nuclear factor kappa B, it activates NF-kappa B. NF-kappa B goes to the nucleus and turns on a lot of potent inflammatory cytokines. So that said, we decided maybe this is the best way to target rather than beta-catenin. As you can appreciate here, in DSG2 mice, we definitely went in knowing that this is a great target to inhibit. As you can see in red, which is the P65 unit of NF-kappa B, when it co-localizes with DAPI, blue, which is the cell nucleus, that means that NF-kappa B has been activated in the cytosol, translocates to the nucleus, it's bound to the DNA, and it's just pumping out a whole bunch of inflammatory cytokines. So we use the same approach as our JCI Insight paper. This data was recently published in Circulation last year, where we use a small molecule compound called Bay11, 7082, to inhibit NF-kappa B. We chose 8 weeks to 16 weeks because we knew they had dysfunction at 8 weeks, and we wanted to take that out until 16 weeks of age when we knew they had biventricular fibrosis. This drug is inserted into what we call an Alzette mini pump, which releases 5 milligrams per kilogram per day of this drug every day for 4 weeks. And then at 12 weeks of age, we remove the pump, refill it, and carry it out for another 4 weeks. As you can appreciate here, not only did the drug delay cardiac dysfunction, but it slightly improved it compared to even wild type. Now, this might be artifactual. However, clearly the drug does prevent progression of cardiac dysfunction. I think more strikingly, you can see that in DSG2 mutant mice treated without Bay11, treated with vehicle, that they have extensive epicardial to endocardial fibrosis in the left ventricle, some epicardial right ventricular fibrosis, but lots of right ventricular outflow tract fibrosis, which was completely ablated in mice treated with Bay11 7082. So that said, we need to know, is the drug truly acting on the myocytes themselves, or is it reducing the transcription of these inflammatory cytokines? In order to prove that, we take these hearts, we crush them up, we get all the proteins out, and we put the proteins, this lysate, onto these basically pieces of paper that have 111 different types of cytokines that we can assess for. I'm not going to go over all 111 because I could talk just about this one slide for probably about 30 minutes. But as you can appreciate here, wild type versus DST2 mutant mice, let's just say cytokine A, we want to talk about what it actually is, but let's just say cytokine A looks similar between the two. But cytokine B is definitely upregulated, obviously, with a whole bunch of other cytokines compared to wild type. However, in mice that are treated with Bay11, this cytokine B is considerably reduced. That said, where are these cytokines actually being produced or coming from? I mean, is it extrinsic? So are the professional inflammatory immune cells, the monocytes, the macrophages that have infiltrated the hearts, are they the one producing it? Or is it intrinsic? Are the myocytes themselves responsible for these large increases of cytokine? I say that because when we look at heart slices from these mice treated with Bay11, not treated with Bay11 or wild type, you can see in these areas of where I have these blue asterisks, these are myocytes. So clearly they are positive for these, or stained positive for these potent inflammatory cytokines such as IL-1 beta, TNF alpha, or the monocyte macrophage chemoattractant protein. So we know that they're producing, that the myocytes themselves are producing these potent inflammatory cytokines. However, these areas where I've outlined in red, these are all inflammatory professional immune cells that have infiltrated the heart. So technically those cytokine arrays that I showed you, those 111 different markers, is a mix, because I've ground the heart up, is a mixture of both myocytes as well as inflammatory immune cells. How do we get around that? So I decided to take iPS cells from a patient who had a polycapillin 2 mutation. We turned those iPS cells into cardiomyocytes in a cell dish. And so those cell dishes are purely, practically 99% cardiomyocytes. We're not making professional immune cells. We're not making monocytes or macrophages. We're making a plate of myocytes. So now we can truly eliminate that variable of an extrinsic infiltrating component. So we do know from here that cardiomyocytes with an ARVD desmosomal mutation produce cytokines. So we know that that this is also coming from the myocytes themselves, and that this can be reduced considerably in myocytes treated with Bay11. Now, that's 111 different cytokines with mouse models, the iPS cells themselves, as well as the supernatant we removed. So the cells are incubating in cell culture media. We took the supernatant and did those cytokine arrays as well, because we want to know, we call it our pseudoserum. We want to know how the myocytes producing, are they secreting those cytokines into the bloodstream? We're not going to go over this so much, but we look for trends. And one of those trends that came out was IL-1 beta, which is the primordial cytokine and is a potent inflammatory marker that mediates the inflammasome. And is implicated in numerous diseases and numerous cardiovascular diseases such as MIs, atherosclerosis, and diabetes. So, like every researcher, clinical or basic, I'm sure we all get on Google Scholar. We enter in like 6 of the key terms that our results say, you know, with and in between, like IL-1 beta and ARVD and something else, and we hit enter and we pray to God that something will come up to explain our results. And I came across this paper in the New England Journal of Medicine called the CANTOS trial, which is a canakinumab anti-inflammatory thrombosis outcome study. It used a drug made by Novartis called canakinumab that specifically targets IL-1 beta. And those outcomes were from 10,000 different individuals who just had a recent myocardial infarction. And the outcomes, numerous outcomes, but I'll just go over just a few of them. Those patients that were treated with canakinumab had reduced recurrent vascular events, reduced hospital readmissions, and reduced pro-inflammatory cytokine level productions. So I reached out to Novartis, said, look, these are our results from our studies with the mice with the Bay11 compound. We would love to test this drug in our mice. Novartis said, we'd love to do it too. However, I can't show you some of this data because I don't have permission from Novartis. However, I said, let's do this mini mouse CANTOS trial. I sent them a proposal. We signed an MTA. They sent me a whole bunch of drugs. Anyone who's ever done research, 100 microliters of an antibody costs about $400 to $500. They sent me a vial, 1.5 mils of antibody. As you can see in my face, I'm super excited because they sent me about 6 or 7 grand worth of antibodies to test, which considerably reduced the cost of my side of this project. The drug works phenomenal. We did different concentrations of it at different time links, but I can't show you that data. However, I think that it went so well that we sent a second proposal to increase our findings at different ages, different stages, 2 different mouse models, one with the plaque globin mutation and one with the desmoglein 2 mutation. And they eagerly joined our efforts so we can expand our study. So in short, microinflammation is a recurrent pathological phenotype in ACM involving the extrinsic component, so the infiltration of these immune cells, as well as an intrinsic component that the myocytes of an ARVD affected heart also are producing very potent, not only cytokines, but chemokines. Chemokines are cytokines that have chemoattractant properties. So they, when secreted by myocyte, they are homing beacons for immune cells to come into the heart. And then we know that the small molecule inhibitor of A11-7082, this inhibitor of NF-kappa B, can reduce and prevent ACM functional and pathological phenotypes in a mouse model and in cell culture. But this expands the pool of currently FDA-approved drugs in ACM treatment, i.e. canakinumab as a potential inhibitor of IL-1 beta in ARVD patients. Of course, I'd like to thank the SADS Foundation for even giving me this opportunity. I greatly appreciate it. I'm humbled by the opportunity. But I'd also like to thank all of my collaborators and funding organizations. That said, I'd like to thank everyone, and I look forward to hearing the rest of the talks.